comment, use the raise hand icon on Zoom to indicate that you would like to make a comment. When you are called on, you will be taken off of mute. Take 2 minutes to make your comment. How to make a comment in person. Sign the public comment sign-in sheet with your name and indicate what agenda item you want to make a comment on. The chair will indicate when it is time for public comment and invite you to the table. Take 2 minutes to make your comment. For additional information, to make a suggestion for agenda items or to contact board members or staff, send an email to dlbcboards@utah.gov. So, approval of the minutes from last month. Has everybody got an opportunity to look over those minutes? Does anybody have any questions or concerns about those minutes? If not, I will take a motion to approve those minutes.
I move to approve. I'll second.
Okay, we have a motion and a second. Can we do an all in favor, right? We don't do, yeah, everybody in favor to approve, say aye.
Aye.
Any opposed? Thank you. I think that passes. Next, we'll move on to the Department of Health and Human Services and the Department of UDAF updates with Mr. Oborn and Dr. Forsyth.
Yeah, I just have a few items to update the board about. One is that I think many of you know that the new medical cannabis card that's issued, the way that looks, the design, that was launched on September 8th. And so we thank the pharmacies and the medical clinics for educating their customers, the patients, about those changes. And we've gotten some good feedback from clinics that they've enjoyed that new version, and the transition to that has been successful. So we're glad that that went well. And at our last meeting, if you remember, I think you all saw a copy of what that would look like. And so we're excited that we were able to make that improvement to the card, so it's easier to use for pharmacies and for patients. And it also does a better job of protecting patient information. So that happened on Monday, September 8th. Also, just a few general statistics is there's now 103,736 active medical cannabis card patient card holders as of the end of last month. And more information about statistics as of last month is available on our website. We have that monthly report posted. So for more information about other stats, you can find those there. We presented at the Rotary Club of Mill Creek on August 21st, and we are grateful for Dr. Forsyth and Des Hennessy for joining us at that meeting. And it was a great opportunity to respond to questions from business leaders in that Mill Creek area. And Des and Dr. Forsyth were especially helpful in answering some of those questions that they're experts in. So we're glad to do that. And then also there's an upcoming medical cannabis presentation on Friday, November 7th. Dr. Matt McKiff, he's presenting at the Southern Utah Family Medicine Conference. That's held at Black Desert Resort in Ivins, Utah. The event's hosted by the Utah Association of Family Practitioners. And so these are individuals that a lot of patients trust, and we're glad that they're having a chance to learn more about the medical cannabis program and best practices for safe use of medical cannabis from Dr. McKiff. And there's more information available at utahafp.org is where information about that conference is available. Also, at the March board meeting, we got input from the board regarding a medical provider survey. If you remember, a representative from the DHHS Office of Health Equity is helping our office with that. And so since then, we've gone back and forth, made some tweaks, and we were able to get approval from the DHHS Institutional Review Board, the IRB Review Board, to for the language and proposal of that study, of that survey. And so we just barely got that approval, and so we plan to email that survey to all Doppel licensed MDs, DOs, APRNs, and PAs and podiatrists later this month. And of course, it's an online survey, and we'll also be posting information about the survey in the EVS, and so people can be reminded about it there if a medical provider is going in. But it's also important to keep in mind the focus of the survey is not medical providers who participate in the program. This is a survey for those who don't participate, learning more about barriers that they've encountered and or questions they may have about the program. So yeah, we're grateful that we were able to get some input, and we can let you know once that officially is sent out. And then we'll be following up with stakeholders about trying to increase the participation in that survey. Stakeholders like health systems and medical clinics to ensure that if they choose to, they can follow up with their medical providers about completing that. That's all. Are there any questions about any of those? Oh, yes. We also do have the medical cannabis product information insert updates, and Trevor, if you can go to that. So we've updated our website to include some changes that we have made to that. And the language, obviously this is the first time you've seen it, so you can take time later on to go. This is currently on our website, so you can go there at medicalcannabis.utah.gov/info. That's where you'll find that. And the language has been simplified. Previously, it did include some information about operating a car or heavy machinery. In the possible side effects section, we removed the weight to drive after using medical cannabis. And the verbiage has been simplified to not include the times for how long to wait to drive or operate machinery based on feedback that we got from board members and others. We removed that part. And so also we simplified the drug interaction section. Can you go to that? And so we simplified that. Just it has more concise information now based on feedback. We felt like that was important to do. It's just more plain language, easier to read through. And also it includes citations. So as a patient or a medical provider or just someone who's interested, they're able to go in and go through, read the document, and then go to the bottom and find where we find information that backs up that statement or phrase that's footnoted there. So those are some of the main differences between the prior version and this version. And there is a PDF that we are just making some final design changes on, but this is the language that will appear in the PDF. So we'll share the PDF with you and stakeholders after that's finalized. And it's a PDF that's one page as the statute states, but it'll be double-sided. And then people that prefer to have a hard copy, a medical cannabis pharmacy can easily print that out, or a medical clinic can easily print that out and provide that hard copy to a patient who prefers to have that. Are there any questions about this? And as a reminder, there's a QR code that a medical cannabis pharmacy is required to provide or they are required to provide a link or the QR code or the actual one pager upon purchase of a product at a medical cannabis pharmacy. So right now, what the pharmacies do is they'll have a QR code, often on the receipt, that'll guide them to that webpage. And we appreciate the feedback that we received, and we value our partnership in making sure that we can provide evidence-based information to patients about products. Any questions about the insert? Great.
Well, also, I was supposed to mention when we were talking about DHS business that the Zoom link, a new Zoom link has been established. So if you guys are following the last one, just notice that it's been updated on the public notice website. Or if you can't find it, you can email us at dlbcboards@utah.gov. That was different, but it reminded me that I was supposed to say that in the beginning. If there's no more questions about that or comments, we can, I guess, turn the time over to Cody, because I don't see Dr. Forsyth here.
Dr. Forsyth is up at the interim talking about freedom. But our famous new program. So just a handful of things here, and just because you guys are waiting for this every meeting, the ICS. But the new ICS is still in the same boat that it has been for the last 6, 7, 12 months. The thing looks like it's looking for the December, January timeframe at this point. We did get some good news that our the Department of Technology Services representative said that is now their number one priority. Hopefully that means that it's going to happen soon. So we'll see. The other thing that affects the industry, mostly the production side of the industry right now, is Anna Farron, who was our licensing board liaison, as well as our licensing specialist for production establishments, has found a new job and is left in position. So we've had that job open. We've got some applicants there that we're starting to review, and hopefully we can get that job filled within the next couple of weeks and be back up to full staff on that. So most things are going to be being handled by Amy and Kevin Millar as far as change requests and coming forward and things like that. So then the last update say is that the independent or the rural pharmacy license that was opened up in July, closed in July. The department has pretty much finished their review. We've actually had some comments from some legislators. So we've always had to put it on hold every time that we got a notice to meet with them based on their concerns and things, which has pushed us back about 2 weeks from where we wanted to be. But we are about done with our internal review, and next week we should be handing those over to the licensing board. Based on that time frame, we're probably going to be holding a meeting in November of the licensing board for them to be able to announce that and go through their process on getting that license to whoever. So we will definitely meet the January time frame, and like I said, more likely it'll be November. Yeah, nothing else to add.
Okay. That was the fastest you've ever been.
I have got to rules yet.
Let's roll into that. Let's start that part.
Perfect. So we brought 3 rules to the board today. The first one is R66-2, which is the processing rule. You may recall we brought it to the board back in April. We made a significant amount of changes at that point. There was some public comment during that time, and then there was some miscommunication from the department. As I had seen the public comments, I did not want that to go into effect, but it still didn't go into effect. And so we, in the meantime, just to make sure we didn't have any issues within the industry or us having to regulate something that we didn't necessarily agree with, we did an emergency rule. That's the emergency rule is currently in place. But in the meantime, we've been working on this new rule. The first thing to take a look at is the definitions. Again, when we brought this to you in April, the Department of Agriculture had not decided to do their initiative on that. We were just doing this kind of on our own to clean up the rules. And so I did not remove any definitions at that point. So you'll see in the definitions portion that we have removed all of those that actually are already stated in statute. There with a couple of exceptions. Down to what used to be 20 and now is 8, is a definition for descriptive product name. This has been in the rule before, but it was down in the body talking about the labeling. So we removed that, and you'll see that as we get down to it. But to remove the definition of descriptive product name up into the definitions there where it probably belongs. And then the second change that is not just removing it for for statutory purposes is what used to be 25. I think, yeah, 25A, but it talks about the product base. We were defining at that point, just based on a lot of conversations, a lot of feedback and really arguments within the industry or industry about how do we start to measure cylindrical containers for the product base. And what we have decided to do is just remove that portion, as well as the measurements for the 50%, and you'll see later on why there. So the product base regulations change, or based on this rule, will be changing quite a bit, and probably for as far as the industry is concerned, for better. That pretty much finishes the definitions. If we just scroll down a little bit down to the labeling portion of things, which is where the majority of these changes from the last statute is going to happen. As you can see in 2-13, 1A3, that's where I took out the, it talks about the descriptive product name, but I took out the definition and again, put it back up top there. Down that same number 1D, for the products containing the THC warning, we wanted to, as you all know, that it says to use one of the warning symbols provided by the department. It used to say including the colors. We'd like to change it to say that contrast conspicuously with the background. So that THC warning symbol could be any color as long as it is either be seen against the background of the label. Moving on down to the portion before, talks about flavor, strains, and terpenes. There was a discussion, and what is currently in the rule, not necessarily in the emergency rule, but what we put in back in April, was that it needed to be printed in the same size and font as the information on the rest of the packaging, with the exception of that the logo brand behind. But what we've changed, or what we'd like to change it to, is to say that flavor, strains, and terpenes just may not be available to children, be recreational thing, as well as my favorite word adjectives. So the size and font portion of that going away there. And moving down a little bit further. In 15, removing the portion that says that the logo or the product brand name cannot exceed 20% of the product face. What it comes down to is that you can go ahead and put that as large as you want to, as long as all of the required information that needs to be on the stat or on the label is there and is legible. Do that. A little bit further down into 16A, removing the directions for use may not be placed on the product face. That was something that was added in April, and then we decided to remove that. And then just a quick word change there on the warnings that can be on the label. Back in April, we said that any of the warnings that are required in the statute can be added to any product. We get multiple warnings if you felt like it. Just they felt like of the should win. So that much. I believe that pretty much sums up all the changes on the new processor rule. Again, the department feels what this does is eases a little bit of the concerns with labeling and should allow the industry to be able to promote their brands. Maybe they won't be able to develop their brand recognition.
Cody?
Yeah.
How will the department be managing what strains, flavors, and adjectives are not approved?
It's pretty much similar to doing with the flavor so far and I'm still enjoying that, so. Basis off of that is making sure that there's not, words that we all should know is appealing to children.
Well, it's not just words,
There's-
it's flavor, strains and terpenes, right?
Right, and so. The terpenes, I don't think is gonna be much of an issue, I think there is a large amount of, I shouldn't say a large amount, there is that. Paragraph in the statute that says that these words can't be used.
Yeah.
Everything in there, so would be recreation stuff, right? We're talking about like, and I think if, remind me what we talked about, JD, but I think we talked about Skittles and they're actually using the SKZ now, things like that. So it's using words like that, making sure they want to similar to that type of thing.
So I mean, will there be guidance put out by UDAF? Because I hear you here saying, hey, you can refer to that list in statute, but that's not what the statute says, right? The statute refers to product names, which is not a strain, right? And also refers to names of licensees. So at the very least, I hope that UDAF would put some guidance out because I can see what is recreational and what is not becoming a huge thing for people to have to deal with. And trademark is one thing, right? That's why Skittles is no longer used in that way. There was a large lawsuit that was settled. Same thing with Gorilla Glue, same thing with Girl Scout cookies. All of that stuff was born out of litigation, not because someone in the industry decided they didn't want to use the name anymore. Trust me, if they could use Skittles, they would still use Skittles. So I would just hope that we get some sort of guidance provided as to what the department deems to be recreational. And I'm not saying it has to be, you know, an exhaustive list, but if it really is going to be that list of terms that's in statute, I hope that some sort of guidance would be sent out and given direction, because otherwise, yeah, I'm sure there are ones that you and I could look at and say absolutely, and then I'm sure there's other ones you and I would look at and you might say recreational because of where you stand, and I might say, hey, I don't think that's recreational because of where I stand. And I think the thing that we want to do is make sure that we get it right, because ultimately the people that are going to be most confused by having to change strain names or having to abbreviate strain names and all those things are going to be patient. So some sort of direction to us as industry as to what the department's interpretation of the word recreational would be super helpful, because it is not defined in the rule, right? What is appealing to children, while not the most precise of definitions, at least is defined, right? And it's something that you can look at. I think recreational is quite frankly an overused term, and one that in some ways I'd be interested to know, you know, what is and what isn't. I think there's some things we first, like I said, for sure could agree to, right? But I think there's some things that are going to be a lot closer. So I would hope that the industry would get some form of guidance instead of just, you know, either some form of a letter of concern or some form of email saying, oh, hey, this product's been in market and now this product has to be removed from market, renamed and relabeled and re-put out to patients. So that's the least of what I hope for. And if not, I don't know if there's a way, obviously at this point, this version of the rule doesn't have it, but maybe trying to establish a definition for the word recreational. Because if it's just going to be that list of no words that was brought up, and invented, I don't know how many legislative cycles ago, then great, let us know that. And that makes it super easy, right? If it is just going to be a defined list, but if it's going to be something, more kind of, less clear, I think even more important that we have an idea where the department's going with it.
I appreciate that. I also appreciate, after we talked about this a couple weeks ago, that now you're talking about all the lawsuits instead of just like.
Oh, no, those were lawsuits not filed against regulators. Those were lawsuits filed against.
You just didn't talk about that at all.
Yeah, I didn't need to.
Oh, okay.
Yeah, no, I didn't. No. Not saying lawsuits to scare you that somehow someone's going to sue
I'm
you.
not scared as much as that when you change your argument.
Yeah, no. By no means does this change my argument. I'm just saying that operators may opt to change names and have opted to change names in the past due to, litigation, either being forced to due to a settlement or doing so, in order to avoid, litigation. And those are things that we talk about internally all the time. As a matter of fact, there was a strain name that we had that someone, brought up and said, I wonder if that term is trademarked. And I said, yes, that term is in fact trademarked, and we should probably use a non-trademark term. So I think it's something we're all going to have to face in a suit. If cannabis is ever, changed at the federal level, you're going to see plant patents and all sorts of different things and all sorts of other trademarks that are allowed. So people are going to have to be thinking about this stuff already. But for what I'm saying is just knowing what you all are thinking. We may or may not agree with it, but just knowing what you all are thinking so we can, kind of do business accordingly, as opposed to just a wait and see approach. Hey, we put this out in market and all of a sudden, it's no longer okay. I think we'd rather get it right before it ever gets to market. I'm sure you guys would too.
Yeah, the recreation portion is a tough thing, because I think, what we're also see is, look around this, the table, none of us are as young as we used to be, and I guarantee there's words that are being used today at, four twenty than what was used at the time. Is this something?
Yes.
But, yeah, understood. So, any other questions on the process? Is public question allowed?
That's up to me.
If, I think we could. I mean, maybe when he's done, we can take some comments about that.
Then I'll go ahead and move on to, the R 66-9, which is the cannabis licensing process. A few changes on this one, try and get on them as quick as I can. At the authority and purpose portion, we needed to add some portions about the, closed door pharmacy and how those are gonna go about getting, licensed or applied for. So that's what the 1206-10 is, as well as adding the closed door medical cannabis pharmacy license wording. This was an interesting rule that every single definition that we had in the rule was actually already in statute. So we just removed definitions completely. Which made this section about cannabis production establishment and pharmacy licensing to 2 instead of 3. A lot of this stuff, again, was kind of just changes that the rules wanted us to be, because they didn't like that we were speaking in either first person or some different things like that. But some other things are just really removing that from, because it was already in statute. So you can see in 3, just will not accept, license applications. It's not complete, to say it may not accept incomplete. It's an example of that. Down on 5 is another example that, just based on statutory changes this last year, obviously they are now, capped pharmacy, licenses, other than the legislature decides to open them up and votes on it like they did there. So a little bit of change in wording there. And then us obviously soliciting for closed door, pharmacies as well, depending on how that looks. So talks about paying the required application fee, some changes down on what is now going to be 3. Not a whole lot, other than the last sentence that said, the new sentence would say the department may conduct face-to-face interviews. But just because we may want to be able to reach out to applicants that ask them questions for clarification there, and then it is kept down to board review of applications and licenses, so that we're able to do that. Next change is down on 4. Is the only change really there on 4 is the applicant's positive committee involved, but that's actually in statute, so remove that. And then I add the factors that are required under parts 441A 2 and 41A 10. They're just talking about what criteria has to be met for the board to take into consideration. There, some additional information about how closed door pharmacies are going to be selected, such as patient needs, existence of PIC, pricing structure, and the applicant's operating plan. There, the new 7, again, as I mentioned before, so the board may conduct face-to-face interviews with an applicant to determine who's the best qualifying person or a group for that license. Interestingly enough, there was almost no statutory language on requiring us to write rules on renewals. So that's not the only reason that we're removing this. There, we are using our broad rulemaking authority with underneath the main agriculture statute, but it's very minimal. They're pretty much starts to talk about when things are going to expire and if we can do the application and then going to the board. But mostly I move those renewal aspects into the specific licensing rules, such as the cultivator, the processor, the farm stuff. So there's just an additional, I got 3 lines. Each one of those, and this one is being removed. So. No real change except for numbering under the public hearing portion. Then obviously this was put in place during COVID, that we could have electronic meetings, and that's what this is. Overall, just really clarifying, adding the things in statute that we needed to about closed door pharmacies. Not making a whole lot of other significant changes other than those things that are already in statute, or we didn't have the right to necessarily have rulemaking authority on, so. That's under licensing. Any questions on that one?
I don't have any.
Alright, so next one is 10, this is the closed door pharmacy rule. So a handful of definition changes, that were already in statute there, so those have been removed here. JD, you may want to take a look at this rule there, and if it's something about recreational disposition, things that's, I think it'll be the new number, 5, which I gotta put a number on, I just do that, but it is, that's been defined, that's actually a definition, I think, that the original DHHS defined early on, or can just copy paste that, but. Next changes after the definitions is really just saying that as far as the license goes, for when we do give out one of these licenses, that it will expire on the same day as the licensee's home delivery pharmacy license. They're just to try and keep it, because they actually have to coexist, that it makes sense to make that they are either renewed or expire on the same day, just so you can't have one without the other. Not that we foresee that specifically happening. Remove the portions about, again, we actually moved this to 9, this portion about what they're gonna determine to do over pharmacy for work. There, that's been removed from this rule, put it to 9, as I mentioned. We took out 4, which is the operating standards, actually took a bunch of that out, and added a little bit to this next portion, which is the new number 4. That is the pharmacy requirements, or closed door medical cannabis pharmacy requirements. Adding the blueprint in there. Limited access areas, things that we need to be able to see what's there for inspection purposes, similar to the rest of the rules that we've done. Protection of cardholder data obviously is there, that's something that was in the pharmacy rule, but wasn't necessarily here, so we've added that, as well as a lot of things about deliveries that we saw in couriers as well, so there's a lot of kind of a couple of rules that overlap each other. Obviously, this would be one for delivery. See there. Some waste information that needs to go on there, and then criminal activity. So actually, all that stuff is actually in other rules, and just we wanted to make sure it was in this one as well. Removing a lot of that stuff. The pharmacist and charge portion, remove that again. As we mentioned, when we talked about pharmacies a couple of months ago, that the Department of Agriculture's authority is not necessarily over the pharmacist in charge, it's actually over the licensee. And so we would, didn't want to have those types of rules in there that were holding the person accountable, but we can't actually want to make sure that the licensee is the person that is making sure things are supposed to be getting done that way.
There is a typo on section 5, number 3. You're getting a little slang in there.
Yeah.
Yeah.
Next change is really into the security standards, and it's just the same thing we did with those other rules, just making sure that there is a minimum standard for the surveillance system, and then also the visitors log. And then removing a lot of that other aspect there about the specifics on the security aspect. It's something that the statute says about being secure and that stuff, and I think that overall it will be a situation that if it's not secure, it'll probably someone push that in will sooner or later to prove it. Well, it's not something that we're going to look for specifics, and we'll leave it up to the licensees to make sure that it's that way and the wrong way. Moving on, after all that stuff has been removed, inventory control. This is a slightly different aspect. Some things here, obviously, you still got the same inventory control about tracking as you would with the pharmacies. But because it's could be in different locations, some other aspects, we're doing the same type of thing about reporting. But that's not the area I want to say that is. Excuse me. Moving that, the rest of that stuff, sorry. But all that was in statute already, transportation is in statute already, so we're moving all that stuff. Inventory obviously says that it's statute about being in real time. Then some changes here on eight, the minimum requirement storage and handling, just, you know, making sure that it's 6 inches off the ground and away from potential contaminants. The disposal of waste is the portion that I wanted to say that we're not necessarily making wholesale changes on, just based on what the possible, at least in our minds, what the possibility of what this closed door pharmacy may look like, may not be a big building, may not have the ability to do disposal or some things like that. So giving them the ability to get that back to the original pharmacy or the big pharmacy, or maybe even into a processor for destruction if need be. And that actually comes under the recalls as well. And then partial filling, remove that portion, we'll remove that in the pharmacy one as well. Changing operating plans and then come to the board. And the differences here with the pharmacies, and there's no changes here, but just when that happens, obviously the revenue reporting aspect of it, because the statute says that only so much money could be made or percentage of money based on the two to keep this going. And then as I mentioned in the earlier rule, that we did put a renewal aspect into this here, which is now will be the new 13. Moved a handful of line, we just kept it in there saying that it's going to expire the same day, and that when the intent to renew has to be there. All of that stuff. Other than that, no other changes. There's a lot of changes there, but mostly it's about removing things that are either already in statute or clarifying it with policy. I think that's it. I think that would be the last time you guys hear from us on the rules until time for this session. Oh, maybe.
Does anybody have any questions about or comments about any of that? On the board? I did see that we had somebody that wanted to comment. You want to come up and we'll take a little public comment in the room and online if we have any. Just make sure to sign the paper and then state your name and your affiliation.
Oh, sure. Maybe they can do box seats.
Yeah. We probably didn't have one for this.
Okay, Alan Roth, thank you, Des, thank you. Director of Compliance and National Initiatives for Pure Leaf. Just wanted to comment upon the changes presented in the draft regarding the control and oversight of string names, particularly I'll comment upon. If I'm not mistaken, I think this was discussed last year. I believe the terminology at that time added, was it sexually explicit? Was in the line there that I believe that was the one thing that everybody agreed upon that should not be in the strain names. But I do believe that the conversations in that time pointed towards the confusion for patients, as JD mentioned, which by the way, I agree with everything he said. I believe that part of the rationale that the industry brought forward at that time was that there's a certain degree of, let's call it, lineage of the efficaciousness of, we're allowed to use that term, the effects of the strain based on the lineage of the names, and a lot of patients know what that is. You might still, unfortunately, if this goes through, be leaving us open to varying degrees of interpretation as to what is recreational, what is appealing to children, etc. So I would say that I agree with JD that some stricter guidelines or information as to what UDAF is looking for here in this would be helpful for the industry so that we can plan ahead. And again, offer comment so that we feel that there is parity and the patients are protected and investment into the lineage of strain is protected, quite honestly. Thank you.
Thank you. Is there anybody online who wants to comment on that?
No hands.
Sweet. Okay, thank you, everybody. We are going to move on to our first item, patient purchasing limits expansion. By recommending medical providers. This is a continued item that we've been talking about the last couple months. And we do have Dr. Morgan on just to get us prepared. I think you'll all remember that we were talking about the small amount of patients that are hitting a limit with their medical cannabis and then being expected to use an out-of-state market or a black market in order to finish their treatment. And a lot of discussion on I think there was a lot of agreement on we wanted to allow that. And then it came down to making a motion, and we wanted some time to make sure that we got it right. So Chris, if you want to take it from there, and he did send out an email. If you guys had the opportunity to read that and respond, I saw there was some response, but we can take some time to discuss that, make a motion, discuss if we like the motion, and move forward.
Yeah, thank you, Des. Just so the board knows, I do have a patient coming in. I need to set up on a telemed with a provider in Nome here in about 15 minutes. So if they do show up on time, Des, if you don't mind kind of taking the discussion for a few minutes while I get them set up.
Yep.
That was just something that's kind of out of my control. I didn't set up that telemed. So first off, I want to give some credit where credit's due. Des had a lot to do with helping prepare this revised points of discussion and potential motion on the purchase limit increase. Yeah, the last couple of months as we have discussed this, I know there's been some back and forth, the 1.5 times the current purchase limit versus, no ceiling on the purchase limits. As we got discussing, Des and I think one of the things would be to allow some incremental increases in both the flower and composite, provided there's medical necessity, and the onus would be on the RMP, of course, to make that determination. And it would be our intention that the RMPs would make those recommendations for increase based on what a reasonable and prudent provider would do. But I think doing it in increments kind of finds a balance between a hard limit versus an unlimited amount that could be purchased. And it would be, of course, based on the patient's individual response to medical cannabis and their usage needs. And that would be, of course, reviewed on every renewal. And those increments could be reduced at any time if the patient seems to not be needing that amount. But at any rate, those incremental increases would reset to the original current limits during the renewal period of their card, and it would have to be renewed again for an additional period of time, whether that be 3 months, 6 months, or a year, depending on the card duration. JD did bring up some good points for clarification. A lot of it had to do with reattesting for each of those incremental increases. Yes, that would be done by the RMP, of course. And I believe this would have to be, my hope, of course, would be that the EVS software would be able to help manage that, where the RMP could, once they've met with the patient and determines that an increase would be appropriate and necessary, that the EVS software would allow the RMP to attest to the fact that there's medical necessity that has been found. They have met with that patient face to face, and that increase is then given. And that attestation could have some universal language in it that speaks to the fact that that face-to-face visit has been done, and that there is medical necessity, and that the PMP as well as DHHS would be able to see that in EVS to confirm that has been done. With that, JD, did that kind of cover those points that or those questions that you had in that email?
Yeah, and the reason I brought it up was just to involve DHHS more in the conversation, and to understand if the EVS, has the ability, probably obviously not right now, but could it be made to have the ability to allow for that? Because to me, it just seems like if not, then our other option is written communications and things like that. And those things can, I know how my email inbox gets to looking from time to time. I'm sure y'all's doesn't look great,
Right.
either. But just making sure that that doesn't get lost, in things. And if it is capable, if the EVS is capable of being, changed to allow for that, that's the reason I asked those questions, not to question the policy. Because as I said, I think this does strike a really good, or a good balance when it comes to, what we're trying to achieve. To me, it's now going to be, how is it done in practice? And it seems like a lot of this stuff would lend itself to the EVS, but I just really ask those questions so DHHS could chime in, as well. Because if it's anything related to the EVS, that is you all's domain, and obviously resources and time that you all would have to find.
Right. And then with each, the last thing on there was as of right now, the patients are required to meet initially with the PMP when they first get their card, and as far as I understand, that requirement is only just a one-time only. In a situation like an increased limit or purchase increase, that requirement would reset, and that patient would need to meet briefly, with the PMP when they go in for their next purchase once that limit has been increased by either 50 grams for flour or 10 grams for composite. Um, other than that, that's all I had for this discussion, and I would hope that the board members. I know this was sent yesterday, but and I'm not sure if everybody had a chance to read that email or go through that email, or if they have any questions regarding these revised points that we'd like to put forward as a motion later.
Do you guys have any comments? Like, I guess for me, I just want to know where everybody is kind of on the board with, reading this motion, moving forward with something like this. What are your concerns? I also know we have people in the room that have dealt with some of these patients that have hit these limits and been faced with needing to find someplace else for them to go. So I do feel like it's important, that we kind of flesh this out and move forward. So if there's not a lot of concerns, maybe, Chris, what do you want to do?
Well, if there's no other questions, I would just like to put that motion out there with those 4 points and have the board vote on it basically as the original draft was put forward yesterday.
Quickly, Chris, I think we do have some people in the room that like to speak, so let me hurry and let them.
Okay.
Let me see if there's anybody online or in the room, but if there's anybody in the room that'd like to speak, just please come up to the table and write your name down and then say who you are and who you're affiliated with.
I'm Chase Angelo Giles, and representing myself. Last time, I talked about the recovery program that I'm working in context of this discussion. And I wanted to provide a guide, and explain it just a little bit, before I give it to you guys, just so that it's on the record, and understood what I was talking. So this guide has, 5 parts. The first part is the part that's what it is. The second part is the 12 steps, and as a free personal resource, I was able to utilize them without licensing according to AA standards. Limits. This part is based on emerging science around something called clinical endocannabinoid deficiency, which is, I would say, kind of like in a similar state to what fibromyalgia was before it was diagnosable, like in that state of science, which I highly recommend everyone look this up on their own. The next part is meetings. This is utilizing existing recovery spaces like AA, NA, Cali Sober, all of the 12 step spaces. And then other steps, this part is the most amazing part of this, and it's where things like full other recovery programs, fitness programs, hobbies, and anything else someone may personally need in their recovery, like anything. That's where that fits in, including other things like other medications. But I've been working this for 3 years. 3 years clean working this, and it has absolutely changed my life to discover, create, work this program. And I did want to make sure that it was on the record so that people knew why I was saying that limits should be unlimited, because with limits, cannabis needs to be there for any time you hit a limit, you need someone to turn. Thanks, guys. I'm gonna leave this with you guys.
Thank you so much. Thanks. Is there anybody
Thank you,
online?
guys.
Well, did you guys? I feel like we've heard from.
Oh.
Good, thank you.
Good.
Okay, Chris, it's back to you if you wanna. Strike a motion, or do not strike. That's the wrong
Make a
one.
motion.
Make the motion, throw out one.
You're
Oh,
muted.
you're
Chris.
mute.
Okay. All right, let me see if I can take a stab at this without crashing and burning like last time. I would like to make a motion to increase patient purchase limits by increments of 50 grams for flower and 10-gram increments for composite when clinically appropriate, as determined by the RMP, at which time the RMP will submit an attestation, the method of which will be determined later, and that those increments expire at card renewal unless refiled by the RMP at the time of renewal. And with each renewal, the patient must meet with the PMP at the time they renew their purchase limit increase.
Yeah, I think one thing is you meant to say. Following any increase. They must re-meet with the PMP, not following
Correct,
any.
yes,
renewal.
yep. Following any increase of the purchase limit, they must revisit with the PMP.
Get that?
Yeah.
Read the motion back.
Yeah, do you want to read it back so we make sure that we get it?
I don't want to get anything wrong, so I'd encourage Chris to reread it for the board as opposed to myself.
And I think it's
It's
just the,
spelled out, right? Yeah.
It's also in the email.
Do you want to just read the motion as written?
Yeah, because he also forgot
You skipped a
Yeah,
few
it
items
is-
in there.
Yeah,
acknowledging medical necessity.
just
Yeah.
read it as written and then we'll,
Okay.
then we be sure we vote on that, how we.
Yeah, let me reread that as we'd written in the draft. The motion is to one The RMP
Just read it,
submits.
start with, I move that the medical, just start there.
Okay, I move that the Medical Cannabis Policy Advisory Board recommend establishing a process allowing RMPs to authorize patient purchasing limit increases, provided one, the RMP submits an attestation to the department acknowledging the medical necessity of the increase. Two, adjustments may apply to flower in 50-gram increments and or composite in 10-gram increments and may be repeated as often as clinically appropriate. Three, increases expire at card renewal unless refiled and may be lowered at any time by the RMP. And four, following any increase, the patient must meet with a PMP for review and care coordination.
Great, thank you.
And I would probably say in one, we want to change it from saying the department to the Department of Health and Human Services. So we clarify what department that is.
Yeah.
I don't think
DHHS.
alcohol, I want to get that. Yeah.
Okay,
It's right
yeah,
to
so we
Cody.
will,
I mean, we understood what the department was, but
Yep.
at least in the memo.
can we get a second on that?
I second that motion.
Okay.
I'll vote. Desiree Hennessy,
Yes,
JD Lawrence,
Yes.
Cami Clark,
Yes.
Matthew Page,
Yes.
Annette Bresci,
yes,
Chris Morgan,
Yes.
Kent Anderson,
Yes.
Misty Smith.
Yes.
That passes 8-0, one being absent.
thank you, thank you. I'm really glad to have that voted on and that we all feel like we came to a good place because it's a tough day when you run into a patient that you can't help and you have the product and you know what can help them and there's a limit and there is still, I mean, because this has to pass in law before it becomes effective, but there's no way to help them right now other than offering them an alternative market or black market product. And I would like to see that change. So thank you all. I'm glad we could all, come from our different walks of life to see that that was important for patients. Next on the agenda, we have the Medical Cannabis Education Roundtable with JD and Nanette.
Yeah, don't want to spend a whole lot of time poring over this memo. I used it more as kind of a starting point for our discussions. Definitely towards the end, there are some questions. Because, based upon my own research, it looks like DHHS has, statutory authority, as well as in their own kind of, internal policies, the ability to put out public education on medical cannabis, including running educational campaigns, and things like that. I know we've heard over time, I believe it was last February, there was a great memo that Trevor put together for us that talked about a lot of the educational campaigns that DHHS has engaged in when it comes to medical cannabis. A lot of that, as I'm sure we all know, is provider and patient focused. There doesn't seem to be a lot of general public education, and that's essentially what you find as you go across the country and look at medical only programs. Quite frankly, I do believe DHHS, Rich, hold on to your seat here. I'm going to give you a compliment here. Has done a better job than a lot of the other, agencies that control, and regulate medical cannabis across the country when it comes to education. For the most part, what you see in these other states is a single website, and some has more information than others. I didn't see a lot about actually going out and educating in the community using a medical provider. I didn't see that they were partnering with, a research center, and some of those things, although there are at least a couple of states that have their own research centers, and are working on, the ability to cultivate, as you guys saw, Kentucky, Mississippi is at the longest running facility in America, and continues to be a leader there. But what I noticed is in medical only states, which you might think would be the states that would be the most apt to provide education, not just to patients and providers, but to the general public around cannabis and the potential, issues that can be created by cannabis legalization, right? We heard, a couple of months ago that there's apparently, diversion happening in the Utah program and it's ending up in the hands of kids. those would seem like perfect topics to educate on if that is truly what is happening in our state, or anywhere. And so, interestingly, or maybe not, because, in states that have adult use, there's a lot more tax money to go around, than in states with, medical programs. And I'm not saying that we all of a sudden create a bunch of tax revenue, and burden patients with having to pay more for their medicine than they already do. But it seems like in those states that maybe have a little bit more resources, they are able to engage in, kind of more far-reaching campaigns. And I provided, several examples. I want to thank Nanette for her input and the research that she did. And so you can see just kind of how things are being handled here in Utah, as well as how things are being handled across the country. I think, I did post some questions in here that I'd be interested to know, UDAF's position. It doesn't look like UDAF has any statutory authority to provide medical cannabis education. So I'd be interested to know if the department has a position on whether they actually, statutory authority or not, could do any form of education. The one topic I always kind of go back to, and I think we talked about it at one time, is, Utah tests for more cannabinoids than any other, program does. There's been a lot to be said about, trying to create, more safe products here in the state of Utah. And I feel like that would be a great topic for, UDAF to educate on. Switching over to DHHS, as I noted, DHHS has done a ton of education, right? But it's mostly been provider and patient, focused. I'd be interested to know the department's position on whether or not they are interested and or feel like they are the qualified public agency to provide some additional, education, in relation to either, youth use or overconsumption or some of these other things, or diversion, or some of these other things that we've heard allegations, without much, Utah-based evidence, to back. Because look, I really believe the answer is not, prohibition. We've had some folks come in front of us and say, oh, we need, THC potency caps. Because if we just cap the amount of THC, that will make it, tougher to get in the hands of children, and that'll make diversion less likely. Or if we just limit the amount that someone can purchase in a month, that means that there won't be diversion. And that means that if there's no diversion, that it won't get into the hands of children. While those general premises may have some validity to them, we just, quite frankly, the evidence has not been presented to all of us to suggest that there is some public health crisis that requires a change in statute. If you're asking me personally, I think that the better avenue with those things as it stands right now would be to educate people about THC potency, educate people about, purchase limits and things like that, educate people about the potential legal troubles they could face for diverting product, even more so diverting that product to youth. Talk to the youth about youth use and why youth use can have impact on the developing brain and all of those types of things. So that's really where I just wanted to start with it. And I'm also not just interested to hear from the departments, but each of you that sit around this table have a different interaction with cannabis, whether it's from a research perspective, whether it's from a provider perspective, whether it be from, I know Chris dropped off, I don't know if he's still on, whether it be from an RMP perspective, whether it be from a patient advocate perspective, and on, right? A producer perspective, all of that. So I'd be interested to know if you all think there are other topics than some that I've discussed and or that have been put forth in other states, what those topics are. And if you agree that some of these topics that have been, approached in different states are worth doing, who would be the right person, or the right group of people to do that? Is that an agency, a state agency? Is that producers? Is that pharmacies? Who is that? So with that, I kind of want to just turn it over to you all to just, provide input as you see fit. We could start with the departments. If not, we can start with board members. I'm open to however this goes.
Des, what do you prefer?
Well, I want to hear from you first.
Sorry, and I will, it is not personal, I'm gonna have to get up and leave in a few minutes, so I just don't.
So say what you need to say. Hurry.
The conversation.
It's okay.
Like,
We'll just hold it against you forever. Don't worry.
We will all be texting under the table about it.
Girl.
So yeah, if you've got to leave, if you have anything to say, say it, because I would love to hear what you guys have to say about, education. I know that there's a lot of misinformation about cannabis, and maybe not even misinformation, a lot of just unknowns about cannabis. So, and cannabis education is hard to come by oftentimes.
Yeah, so this is Rich Olborn with Department of Health and Human Services, Center for Medical Cannabis. And the priority of DHHS has been to educate the participating patients in the program and also the medical providers in the program and within the budget constraints that we have. And the subject of how we've done that, that's come up in a previous meeting, and so I don't think we need to go over that too much. But something that also recognizes that there's language in the statute, and it talks about public education campaigns, not general education efforts. And so what we believe is that current statute restricts the use of the patient enterprise fund to education surrounding medical cannabis, but not illicit cannabis use, youth cannabis use, or cannabis produced by other states. So there's the specific term when it comes to 26B4 243 is medical cannabis, right? So I think we from that gather the focus is medical cannabis, not illicit cannabis use, youth cannabis use, or cannabis produced in other states. So a statute change would be required to broaden that scope.
Okay.
Let me ask
yeah, I
this,
think
Rich.
that hits one of the
Does,
issues.
is DHHS allowed, like, let's say we're talking about another, another controlled substance that may get into the hands of a child, right? So say I have a prescription and my child gets access to it. Are you guys allowed to provide education generally around how to prevent youth from gaining access to prescribed medications? Has the department ever done that in other contexts?
It really depends on the statutes and what our statutory authority is per. So CMC has some very specific statutory authority. Office of Licensing has some very specific statutory authority. So what is and isn't allowed is through that. What we can say is that the enterprise fund, which fully funds what CMC does, cannot at this time be used for education except for medical cannabis. Now, we do have, I think Rich can talk a little bit about, we have a campaign that was formerly called Gray Matters. We're doing some rebranding kind of that, which is run through another of our OUs, operational units, sorry, so called divisions and things like that. Apologize for the jargon. That does talk about kind of the dangers of youth cannabis use. So it's done through a different division under the department and with different dollars.
So basically, we could educate, or the Department of Health does have license to educate on COAs and the safe and efficacious products that are sold in our pharmacies, right? You could do education on how to read labels, on how to store it safely as a patient.
And we've done some just basic education about that in our newsletters that we send out. And the question would be budget constraints.
Right.
Because there's a big difference between a campaign where you're purchasing, costing a lot of money, and then our priority has been, due to some of the budget constraints, is let's focus on the patients in the program. And we know who they all are. So we've educated them on those topics that you mentioned. And medical providers as well.
Right, but we know about half of our patients are leaving the state or purchasing from black markets. Maybe if they had more faith in the program and a state sanctioned, hey, this is trusted product. This is why you don't want to go out of state. We have the COAs. We know that it's safe. You don't get that same thing in rec markets in the 3 states that surround us, right? So those are maybe would give patients that confidence and make it worth it for them to be purchasing in our program instead of that going somewhere else, right? And that diversion.
Yeah. Definitely hear that. One thing, do want to let, so JD, I think you had questions about campaigns. We have a Know Your Script campaign.
Yep.
So that does very much, so that is another place where we do education on ensuring you store your medications safely, ensuring that they're out of reach of children, etc. So this is another piece where anybody who has a prescribed medication, of course, we recommend medical cannabis. We don't prescribe medical cannabis there. And I hear absolutely what you're saying on the concerns around diversion and all of those items. Again, we have to, the way that the statute is written, we legally, there's a lot of which come out, we can't do. We are discussing, we've talked about this a few times in here, the validity of maybe pursuing a statute change, so we can widen what we can do for other types of education around that. That is in process. I know we all would love for it to move faster, but the wheels of state agency turn slow.
Yeah.
But as soon as we have an update on that, we will give it to you, because we do hear very much your concern on this. We simply are bound by our statute with what we can do with enterprise fund dollars. And then what we can do overall, we have about, and I think Rich spoke a little bit to this, that there is a difference between, and I think that you quoted some internal policy in your memo. And that's, I think the thing that's important to understand is that policy is around what we could do once an education campaign is selected and formed by the department, not what we have to do and what we have to do around education, which are two separate things, because education campaigns are actually generally contracted out to a third party. There's a lot of other things surrounding that. But that these smaller education efforts just really dictated OU to OU and depending on our statutory authority there.
So are you saying that the department is actively seeking a change to statute to broaden your educational capabilities?
Discussing what would make sense there, which I think we've talked about that a few times before in this meeting, and as soon as we have an update, we will definitely give it to this board. The reality is we are an executive agency and there are many steps we go through before we decide what to prioritize and what we can and what makes sense with what the governor's priorities are, because that's our role.
One education piece that I feel like has to land, has to be done at the Department of Health and Human Services is the kind of the doctor education. I mean, especially with this change from the QMP to the RMP. I mean, that opens the door to do the thing that we have been saying since 2016. Let's let doctors be doctors. And I would love to see if I don't know if there needs to be a rule change for this or whatever, but in the very beginning of after, when it was the Wild Wild West, we called it, when it was the letter program, right? I spent hours a day calling clinics and explaining to them that they could write these letters. And at that time, their emails were online. They've since been removed, but that doesn't matter. It doesn't seem like they ever opened an email, but they're incapable once they get their doctorate. And so but we, as a community, as a medical cannabis community, we don't have access to provider information. And I know that you guys do. And I think a big piece of this is allowing doctors to know that they can do this. They can do it for the cost of a copay, that the Department of Health recognizes this as a medication in the state of Utah, whether or not you support it or not, but you do recognize it. And so then even just, I don't know if you can send a link of like education, like, hey, here are some things, but the ball is now in your court. Your patients don't have to doctor shop anymore. They don't have to go outside and find somebody to do a cash payment. They can talk to you at regular doctor visits. I mean, this change is massive in the way of actually pushing medical cannabis into the medical market. I mean, this is huge, but almost every patient I talk to, their doctor still has no idea. I mean, granted, it's been 2 months and things are slow, but I would love to see, a plan or a program or something put in place that the doctors know that you guys support this, because there was a huge campaign done in the beginning, right after the passage of Prop 2, to explain to them, and the letter is still available, but that was written and sent out to all of the doctors that said, basically, if you do this, if you write a medical cannabis card, you are subject to losing your license. And it was sent to everybody, like every doctor in the UMA and a couple other the smaller doctor associations. And so the fear was presented before they ever had the opportunity. And I think that did push a lot of doctors into just saying, hey, these are the doctors that are doing it. I'm not. And I would love to see some kind of education on just, extending that olive branch, maybe is the word, I guess, to say that, like, hey, cannabis is okay with us. Like, we are recognizing as a medication. Here is how you can feel comfortable, go and do. At least just letting them know that it is available for them to have that conversation with their patient would, to me, be, I would be amazing.
Well, and I think we can speak to like that is what the reason we're doing the provider survey or sending it out to all
Yeah.
providers that are qualified that aren't recommending, because so we can understand
Why?
why they're not, so we can do targeted education, because we want to make sure the dollars we spend with that are actually hitting the right thing. We understand what is that barrier. So I think you will see that we are in the beginning stages. This is our first step of doing this, so we can truly understand where those barriers are, because I mean, what you talked about, this is, doctors know how to do their business, right?
Yeah.
And hopefully you saw some of those shifts in the patient product insert.
Yeah.
To really, underscore that.
Mhm.
And so, yes, I agree. This is. Patients have said time and time again, and we did surveys a few times, who they trust to give them their information is their medical provider.
And the medical providers trust you. They don't trust me as much when I call.
Yeah, just.
Like when I call, it's like, thanks very much. But from you it does, but this, I think the shift, putting, creating this RMP program is what's going to, it's our biggest defense against a recreational market. And, it's our biggest defense, about keeping patients inside of our program. And so I really want to make sure that we're giving doctors all of the tools that they need to feel comfortable to get on board and be there for their patients in this way if that's what's needed.
One thing I'll just add is the survey will help us sharpen a focus.
Yeah.
Of where we can target education, whatever that looks like. No matter what, the survey is going to help us gather intel about what medical providers feel, those that are not participating in the program. And so we'll keep you informed as that moves forward.
Providers,
Yeah.
Yeah.
if you're not recommending these papers.
Yeah.
Yeah.
And we're
Is
clear.
it out?
No,
Okay.
it is going out before the end of this month. We're just working with the Office of Health Equity, and we can make sure that.
Make sure that we get it.
See it. And we'll be reaching out not just to you as stakeholders, Utah Patients Coalition and Uninet, but also other stakeholders like medical clinics.
Love it, yeah.
And also health systems and groups to help us spread information to follow up on the email that would have been sent already directly to the medical provider. But we're using the survey to gather information, not to persuade providers one way or another.
Right.
Let's gather information, and so we can sharpen whatever message and how we send it, what method we send it by. We're learning this in the survey.
I love surveys.
Okay.
All right, well, I guess we've heard from DHHS now. Be interested to hear from UDAF, who, to this point has not, necessarily engaged in the same type of education as the department. I'm wondering, as DHHS, wondering if that's because of the lack of statutory authority or otherwise. And even if there is no statutory authority, does the department feel like, it has the ability to provide any education? And if so, what topics it might be best to educate on?
Yeah, so Department of Agriculture, we agree that there's no requirement regulatory wise for us to educate. That being said, I think that there's nothing that obviously stops us either. I mean, I think, as Rich mentioned, quite a bit that going to different meetings and educational seminars, stuff, we speak at those all the time, type of thing, right? All of us do at state agencies. The department is open to the authorization of, to educate if it feels like it needs to be in statute. Probably not open to a mandated, or wording of mandates, what exactly to say. Type of thing, right? Education should be education. The third question that you asked JD was, what topics? And that's where it gets probably a bit different than what maybe the industry and the patients are expecting, with the exception of maybe COAs and stuff, right? Our expertise is in the regulations and testing, right? And so the COA can maybe give you that type of thing, talk about what it takes to be legal, what compliance is. Obviously, the big thing that always comes up is the possible difference between, you know, the testing and the safety of the medical cannabis industry product versus, you know, black market product, which was mentioned today. Again, just an overall probably education on the testing of that nature for safety, but again, fall underneath our probably expertise. Four is just kind of the, what we don't necessarily feel comfortable with. And that would be pretty much the use, the benefits of also, that's just not our expertise as far as like those, as I mentioned in number three. You know, we would for that, as you guys mentioned in topics at DHS, quite a lot about that, but you know, where other health authorities, right, wherever the expertise lies, whether it's through the right, anybody who's doing any type of, you know, academic work or anything like that, where it's actually coming out of that, so. And then your last question was, could DHHS and EDF collaborate to provide education? And I think so. I think that kind of what was mentioned before is what their expertise are on with our expertise, how that kind of comes together, and when really the safety and the legality of the program, street program is probably feel most comfortable with it.
So if I summarize what you said, just generally is the department will be open to a potential statutory change, you know, basically delegating authority to you all to provide education around just medical cannabis, like DHHS has said, or will the department feel comfortable providing education generally about cannabis? Because if we are going to get into black market, right, or illicit, you know, sources versus regulated and legal sources, according to DHHS, that's no longer in the realm of medical cannabis. That's not just cannabis generally. So that is a question. And then I think the other thing that I think I heard you say is that while you're open to that, you don't want the statute to be, any statutory change to be so specific that it mandates exactly what topics you have to
Not
educate.
necessarily what topics as much as, I mean, because if they want specific things, we do that through.
So you're saying more content based, like
Content-based,
exactly what it has to say? Okay.
I don't think anybody really wants anybody to come out there and just blatantly say, hey, you know, this is what it is and it's not really that type of thing, whatever the situation may be. I think the department and taking into account what DHHS mentioned and how they work, it is a very big agency, so they do have a lot of hoops to jump through to get any answers. We can do that a lot quicker, a lot smaller type thing. And so I think that based on your question, you know, the black market and stuff and how that affects it, we would probably look at that as within our realm to talk about the two things, because as long as that base subject is medical cannabis, and we may be comparing to that thing, and that again is based on the regulations and safety of the testing.
Yeah, because one reason I bring that distinction up is if you read the statutory provisions around what we as operators can do, there are times where we can educate on topics that may have, to use the term the hot button term of the day, have a recreational disposition, as long as we then contextualize that, right, in terms of medical cannabis. So I think it's interesting to hear your department say, yeah, that feels like that's within our wheelhouse. Very interesting that statutorily that is within the wheelhouse of us as providers or as producers, as well as pharmacies and things like that. But then to hear our public health agency who is in charge of this and who actually wrote a letter back to a group who came into this room and made some incredible claims about youth use, diversion, and putting it all on the medical cannabis program, says that that's not part of medical cannabis. I just find that to be somewhat interesting, and I think definitely warrants further debate, and maybe it requires a statutory change. But it's good to hear that the department is willing, statutorily, or not, to engage in some of that education, because to me, I think the point is, if we want Utahns who are seeking to use medical cannabis to go through the process of becoming a patient, go through the process of becoming purchase eligible and continuing to shop in this market as long as they are consuming cannabis, we need to be able to promote it as well. And that is one thing, that is the main reason that I cited the policy, the internal policy from DHHS, was to say that it says right in your own internal policies, you can promote cannabis. And I'm not saying you have to go out and advertise in the way that a producer would or that a pharmacy would, but the always kind of yeah buts that we seem to get around promoting it sometimes is difficult to to square. And I guess one of my questions would be, are there other types of medications or health concerns or problems that DHHS in the past has promoted? And if so, what is the definition of promotion? Because when we talk about education, the conversation seems to always kind of stop at that. We can't be pro medical cannabis. And I understand you have to be evidence driven and stuff, but is there not a way that we can promote that Utah has a medical cannabis program that has over 100,000 people in the program? We have some of the most well-regulated and well-tested products. We have a limited license market that may not be working for everyone, but it is working for over 100,000 people who still have cards today. And part of what we want to do is promote bringing that 50% of patients, or what, 40% of patients, depending on which numbers you look at, that are not purchasing in the market on a monthly basis. It seems like we stop just short of trying to promote the fact that Utah has a medical cannabis program, unless it is strictly to patients or to providers. So how does the Department of Health and Human Services feel like it could engage in some type of promotion around medical cannabis to try to ensure that anyone in Utah that wants to use medical cannabis at least knows where to find it and that it's even legal? Because still there are a number of people that I run into that are astounded that Utah even has a legal medical cannabis program. So I know that's a mouthful, and feel free to answer some, all or none, but just some additional thoughts.
Yeah, and appreciate those. One thing I want to clarify is that statute always trumps policy. So we could have a policy around anything, and if statute does not explicitly allow, it doesn't matter what our policy is. So I just want to be clear about that.
Certainly, and I hate to cut you off, but it does say that you are allowed to provide education around other topics related to medical cannabis use as determined by the department. Seems to be quite broad. So that doesn't seem to suggest there's no ability to promote, right? That you know what I mean? So then I guess I would then look to your internal policies that seem to be more specific than your statutory authority, and don't seem to be limited in terms of your statutory authority to say, does the department feel like there are areas in which it could promote the medical cannabis program in Utah?
So we do not actually promote any specific medication. That is kind of where our stance and our policy is. So we would not promote, we would not make a choosing to promote and say you should use medical cannabis, or hey, go talk to your doctor about medical cannabis, would not be in, it would be treating medical cannabis differently than we really treat anything outside of like a pandemic. And even in those cases, we generally contract with like local health departments or others to do that kind of work. So and that is, and I know that doesn't feel good. I know that's not what you guys want to hear, but that's kind of where we are. And again, we recognize that there are places education could happen. We have found, based on all of our surveys and our work, that the best place to give that education and spend our limited dollars right now, based on how our attorneys interpret our statute, is for patients and doctors. So not just doctors, I want to use recommending medical providers. Because on the record, more than just MDs can prescribe, right, recommend, whoo, get the words right. And so we want to do what we can in that area right now and recognize that there will be some benefit to addressing the wording in the statute. Because intentionally or not, that's how it's worded and that's what we're held to. So, like I said, as soon as we have an update on where we may be going with that, we will let this, but just, we are aware and we do understand it probably can feel frustrating on your side.
I think as patients, you know, especially people who purchase weekly are putting into that fund weekly and have been for 5 years. Right? And they're not getting the education that they deserve from the Department of Health saying, this is safe, this is a safe program. These are all the steps we've taken to make sure that this is a safe program. I just think it would give patients a confidence that would.
I would love to hear where you feel like for patients there could be, because I think, you know, we have this information on the website we have provided on our end, which is different. And I think that UDAF has a lot of work that they do subtly on their end, even if it's not like their statute, with actually the quality of the product and the assurance is there, which is really where we would see that's their wheelhouse, not necessarily our wheelhouse.
And dosing forms, who would take that one? Because, right, it's so that.
Yeah.
There's
Everyone in the room pointing to go right now, but it's just no pressure.
There's so many little nuances,
I
and
hear
like,
you.
I don't see that patients know what are available and what even to ask for, right? Most patients don't know what is out there in that sense.
Am I sorry, you're actually supposed to be calling on us and telling us, are you
So,
okay if I
to that
I said
point,
discussion.
I would remind everyone that also the CMCR has produced these instructional videos that helps inform not only providers how to speak with patients, but patients how to speak with providers, and most importantly, because really the in-depth conversations I think are happening at the pharmacist level. And there's an instructional video on facilitating meaningful conversations with the pharmacist.
Right.
And they're
broken down really nicely. The
Yeah.
videos are broken down really.
They really user friendly.
I mean, at this point, they're outdated because the RMP program has changed those. And so every single one of those are outdated. at this
Well, the
point,
pharmacist.
right?
The pharmacist,
One is,
updated.
I watched all 3 of them. several times this
they
last
are,
week.
yeah, they will be updated.
Yeah.
So. But they're a good launching point that we didn't have previously. And although some of the labels have changed, the subject matter of the conversations still hold
They're
true.
not super patient focused, in my opinion. So I just don't feel like those are patient educational videos. But
Yeah.
they're about the program, yes, but they are not about.
but about like, so you want like patient usage, like how do you, like, how do you use this specific product? Or what are you expecting to see when you use this product?
Right, yeah.
Cause I mean, it is true, like if you use, I mean, if you're recommended another medication, that's like, there's a prescribed medication, there's a lot of information out there, and with cannabis, there just doesn't seem to be, and it is weird, like UPC talked a couple years ago about like making videos about like, I mean, it was so ridiculous, but like people would come to us like, we don't know how to inhale. And it's like, who does that? Who handles that topic of how do you inhale, and when is an inhalant better than an edible? And some of those conversations happen with a pharmacist, some of them are forgotten, some patients want to know before they walk in. You know, so is that what you're talking about? Like just this, like, I mean, there are people that literally don't know how to use it, and they don't know what the side effects are, and so you're thinking like the Department of Health or
CMCR.
Yeah, CMCR is like a hub of, we can have all of the data there, all the information there, and patients can not have to go searching.
Yes.
So maybe more clarity,
Well,
more.
Why did we require the top 5 terpenes to be listed on a COA? do we talk about terpenes? Do we educate about terpenes? A lot of our arguments are, focused on patients seeking high percentage rates in flour and dosage forms or whatever. But a lot of that is because of education and people aren't knowledgeable about terpenes, right? But that's UDAS testing, so I think they could come out and say educational piece, yeah.
But
there's
they
a lot-
can't use adjectives, and
No.
how do you say,
Right,
this does this, if you can't use an adjective? Like,
And as a regulatory agency, right, we're almost completely reactionary on that. So I can tell you exactly what the turbine is, and it's the same thing with the pharmacies having to put the back panel on the website, but it's because we do get complaints or whatnot from patients that I don't know this, I'm not getting this information or not. And kind of to your point, no one's explaining it to them. But then like the turbine ones, and it's interesting because obviously, or at least in online, I should say, at least the people that were coming to us and asking to be able to know that already knew about it, right, and stuff. And so they're just at that point, the loudest ones that they know about turbine, but you're right, there's no radio people who probably don't even care either. And or don't know or anything in between, right?
Well, I would even say there's another low hanging fruit that could be it might be a good partnership between Department of Ag and other entities, whether it's the CMCR, the Center for Human Toxicology, or even the Poison Control Center, I don't know. But, ever since 2020, when University of Mississippi published the report on over-the-counter products that had hugely varying actual content of CBD and sometimes even other cannabinoids in what was allegedly hemp and therefore eligible for over-the-counter products. There's been a lot of people looking at over-the-counter products here, but that hasn't been coalesced in any way, that hasn't been made publicly available in any way. And I think that really Department of Ag is really well positioned to assist with that and or even partner with some of the investigators at the U or anywhere else in the state that has either some background research or some interest in putting something like that together. So one of the strengths of the program is the rigor and the safety that the medical program offers. So if you can say, this is a real strength, we can offer this to you and we can offer this level of safety. I think the data is actually already out there, it just hasn't been coalesced. And no one's taken the lead to sit here and write it up.
keep it medical.
So, yes. So, something to think about.
All right, we've heard from both of the departments. Just interested if anybody else on the board is interested in talking about, cannabis education and potential topics. And who might be, best to do that education. If not, then I think that probably concludes our discussion.
From my perspective, I think that the youth use and prevention topics, as well as the legal versus illegal use, are really great topics that I'd like to see covered. And I do feel like it offers some legitimacy to the program for people that are as far outside of it as somebody like me is. It's nice to look in and go, well, this seems like a balanced approach to this conversation. They're talking about youth use and its impact. They're talking about prevention. They're talking about legal versus illegal, how to do this correctly. And that makes it feel very legitimate and real and thoughtful, where I think sometimes it can, from a totally outside person, it can feel sometimes unbalanced. And so I think those educational topics could offer a balance that's currently lacking.
For sure. Who do you think would be, like, from your point of view, who do you think would be best to offer that kind of education? Because, we as industry could offer that education, but I'm sure you can guess how that might be received by the general public. Is that something that CMCR should be educating on? Don't know if that's within the statutory, kind of authority of CMCR. If you're asking me, I think that's the domain of a public health agency. And hence why, either that or if you don't think that it's within your wheelhouse to be able to do so, partnering with another, another outside vendor. I mean, we heard the department here say today that the Gray Matters campaign, while not through the Center for Medical Cannabis, was through another arm of DHHS. And Rich, what part of DHHS was that partnered
That's the
with Gray
tobacco
Matters?
prevention and control. Tobacco prevention and control. And yeah, the funding is separated. A lot of it came from local health departments. And the campaign focused on educating parents on how to help their teens understand cannabis use dangers. That was the focus of it.
Yeah, definitely saw their billboards all over the state.
Yeah.
So Rich, I guess let me ask you this, and not to have, you don't have to give me a firm answer, but I know you all are thinking about approaching the legislature about some statutory changes. Would the department be open to having its kind of, educational wheelhouse be opened up beyond just how it's currently being interpreted? Would the department, like, the Center for Medical Cannabis, feel comfortable educating on youth use and diversion and those types of things? If, I get it. If a statutory change is made, you'll do it, the statute tells you.
Yeah.
But have there been discussions within the department? Because like I said, there was a response written to a letter, and part of that letter, right, talked specifically about the need for education. And the response letter said, yeah, we agree with you, on the need for greater education. And the topics, that they seem to be, talking about were, youth use and, some of these other things, diversion and stuff like that. So would the department be open to that, regardless of whether it's foisted upon you by statute or not? Is that something that the department feels comfortable, educating on?
I'm not prepared to give a position on it. It's something that can be evaluated. Yeah. So something to be evaluated, the board can discuss it and make recommendations.
I mean, JD, it sounds like a motion needs to be made to push the statutory change to get education as more a priority.
Yeah, and I think that's probably what we do next month, is just come back
Yeah.
with
Or
a
work with you
motion
on something.
like Chris had done. Yeah, we can just put together a motion. I mean, quite frankly, it's something that I plan to work on outside of this board
Yeah.
anyways, because I think there have just been some incredible claims made, whether it was last legislative session or even in a publicly disseminated letter that obviously, warranted, a departmental response. Because, we got to tell the truth on all sides of this. And that is one thing I do, appreciate about what DHHS has done with their educational efforts from their purview. They are telling the truth that they feel like they can tell about medical cannabis. I don't feel like there's hiding the ball, but it feels like we get to a place where there's not enough of it. And if we aren't educating on this and telling the truth about it, people who have an agenda against cannabis are going to fill that void. And I would just hate to see them, be able to sabotage, what everyone in this board works so hard on, not just once a month, but some of us for our careers, some of us for parts of our careers, and the people in the room, that rely on this, and the 100,000 plus people that have a medical cannabis card in Utah. I would hate to see us, further jeopardize our program, but really more than that, further jeopardize our patients and force them to continue to cross state lines, force them to find illicit sources for their cannabis when they can find it right here in the state of Utah. And some of it too might end up being that we need to, look at at industry as well. Not just based on what we're currently allowed to do, because I think there is some things that industry could do a better job of educating on. But I do see, a variety of people within the industry doing that too. So to say it's not out there would be a misnomer too, but maybe there's some statutory changes that are needed that open up, what we can and can't educate on as well, because the rules are pretty, are pretty strict on what kind of education we can and can't, provide. So I think it's something, to me, it's a topic that's just generally needed, because if we're going to give airtime to some of the things that we've heard, we should certainly give airtime and put resources behind, the other side of it as well.
Yeah.
So yeah, I'll come back prepared with a motion next month.
Is there anybody in the room that would like to make public comment on this?
Anybody, Mayor, with Dragonflies? The regulatory bodies as well as the board, in this room, have the ability to address the two biggest problems, in our medical cannabis program. That's accessibility through Department of Health and Human Services, and the price. And the price, quite frankly, is always going to be compared to the illicit market. And people need to understand that there's a cost associated with that. And I believe that is where UDAF has the opportunity to say, well, this is why cannabis does cost more in our state. Because it is regulated, it is tested, it is full panel testing, all the things that you don't get in other places. And I don't see that as being pro cannabis at all. But short of that, I think that's wherein lies the problem, right? And if we just look at the regulatory bodies as a business, we start and ask, why? Why is the Department of Health here serving the medical cannabis program? Why is UDAF here to serve the medical cannabis program? What is our why? What is our mission statement? At Dragonfly Wellness, our mission statement is to bring health and happiness to our community. It is a clear guiding North Star as to what we are here to offer to the public and offer to our patients. Guys, it's in putting patients first, putting quality first, putting integrity first, and we all work towards that common goal. And I think the challenge is, who is responsible for making sure that we have a successful program? Who is actually responsible for growing the medical cannabis program? Because if it was a business, your boss would say, let me look at your KPIs, let me look at your revenue year over year. And it is run like a business, like any other, and regulatory agency is still a business at the end of the day. So understanding what a clear mission for the purpose of our leaders within the medical cannabis program, at least allows industry, allows patient advocacy groups, allows other people to understand, how do I work with these bodies? Because right now, I could have maybe 20 more seconds. Because right now, sometimes it's difficult to understand, is UDAF's role to make sure that there is no diversion of legal medical cannabis product based on regulatory controls and rules. It seems like that's their only kind of rules, to let's make sure that this product doesn't get anywhere, that these operators don't step out of line. And from a DHS perspective, kind of same thing. Is it just to help the people that are existing patients and providers, to actually help the people that have no clue that there's medical cannabis here in our state? To allude to what JD had mentioned, every single day we still meet somebody who has no idea. And if I were to measure a stick and say, how good are you doing as a job? If a vast majority of people have no idea we have legal medical cannabis, I would say we're probably failing at that part. So.
Thank you, thank you.
Thank you.
Next, just come up, state your name, and you have 2 minutes, unless you keep talking and I don't have the.
Hi,
And
I'm
I
Chase.
don't pay attention.
Hi, I'm Chase Angelo Giles again. So let me just grab out I got a list of things that I want to mention real quick. Oh, okay, I'm ready to go. Just to I'm building upon my last one, as well as talking about some new things that are relevant to this discussion. So the name of the program is Green, Clean, and Serene, and it's public domain. Just wanted to mention that on the record in my time frame. But something that we need to take note of is all of the social media advocacy, all of the and education going on there. There are a lot of people who are currently educating, through social media. I'm one of them. I don't get paid for it. And I'll just quickly link, if you guys want to look into my story a bit, it's that one guy from Utah on Instagram. I talk about cannabis education, from the physical to the spiritual and everything in between, well beyond that too. But my primary focus is usually education. And I've covered a lot of topics, including that we have a program. But one big topic that I think that we should cover is Utah is good at cannabinoid variety of products. We have a lot of products with what is called an entourage effect. And I don't see that too much or emphasized much out of our state, but not as much as we do. Something to keep in mind with that is eating an edible versus smoking cannabis or vaping here in Utah leads to two different chemicals. In normal inhaled cannabis, you have delta-9 THC. But when you eat it, your tummy turns it into something called 11-hydroxy THC, a completely different drug. But people get medical value out of both, and often in combination. that obviously telling people how different things interact is great for in regards to education on reading labels and things like that. Getting people hyped to actually look at them. Could I have 20 more seconds maybe?
Yes.
Yeah, so getting people hyped to read the labels because they're like, oh, there's CBG in this. And I read on the, the department's thing that's posted at the pharmacy that CBG can help with so and so and so. Or it's known to, or a big thing to keep in mind is we can talk about these things from personal perspective, offering patient reviews and feedback as a way to, describe it without actually putting our feet in the ground. Okay, I think I covered everything. I was gonna mention something about terpenes and fruit being a cool educational topic, but that could say that for another day.
Well, good, then you have to come back. Thank you, thank
For
you.
sure. And thank you.
Hi all, Alan Roth, Curaleaf, Director of Compliance. Just wanted to offer something for consideration as to approach with all of this. I think everybody's expressed many different points of view, but I want to refer to a conversation I had with Trevor. And it had to do with the creation of the patient information page. And I think what I want to say is really about mindset and the manner in which one communicates to the people you're trying to communicate to. In my studies of communication, the highest point seems to be communicating so as to be received. Otherwise, it's sort of wasted time. And my comment initially with Trevor was that if one needs to be evidentiary based, wouldn't it be possible at the top line of the patient information to say, Utah has approved the safe use of medical cannabis? It's a very simple, welcoming and warm sort of embracing thing. It's not huge, but it is an intent of just saying, hey, this is a thing, it's here, right? And I just for the heck of it, I Googled New Jersey DOH, Department of Health, medical cannabis. Brings it to the CRC website. And the first line says, New Jersey's medicinal cannabis program helps registered patients under the care of licensed healthcare practitioners safely access cannabis-based medicines from regulated and monitored facilities. Evidentiary, it's a little bit warmer than medical cannabis is a treatment that uses cannabis sativa plant to treat the symptoms for certain specific medical conditions, such as pain, seizures, or cancer. Now, I appreciate it all, and I get that there's varying levels of education. Can I get 20 more seconds, please?
Everybody else did, yeah.
And really, no soapbox here, just trying to say that communicating effectively is it's an approach, it's a mindset. And I think there's potential middle ground here for everybody. If we just look at what are we trying to say, how are we going to say it, and how are we making people feel maybe supplied. Thank you.
Thank you, thank you. Is there anyone online?
Yeah. The Blake.
Blake.
Should just give him 220. Oh, he's pretty fast.
Hi, everybody. Blake Smith with Zion Pharmaceuticals. Can everyone hear me?
Yeah.
I'll make this quick. I really appreciate Alan's comments. I think he's spot on. How we approach communication makes a huge difference. And I also want to just say I completely support JD and everything JD has said. I always find it interesting and slightly problematic when agencies rely on statute as to why they do or do not do something, because statute can always be changed. And so I think industry has really tried hard to make sure that we're doing our best, that we're all trying to do what's right for patients and working with the departments to do so. If it's simply a statute issue, we can change that. And I like the idea of us continuing to work together rather than being adversarial, because we can get it changed almost any way we want if we do the right thing by it. The last thing is, I would say departments ought to probably, if they don't like cannabis road warriors talking about how they think it all works and science and so forth, then someone needs to become the experts in the departments to have that conversation. And that's probably the right way to think about that. If not, you're missing an opportunity. And with public health, as well as patients trusting the departments to be the experts in these areas. And so, anyway, that's all I have to say. Thank you.
Thanks, Blake. Thanks, Blake.
Okay. Well, then maybe we will look forward to hearing more about this next month. Can you just send it to an email to the board and then, yeah,
Do we have the same? It's still the same. Or is that?
That's the new one.
it's the new one. We have the new email. Yeah. It's our new email is dlbcboards@utah.gov. Yeah. Okay, we're gonna quickly move on to our next agenda item, the future topics for board discussions. And I think that this is a great segue because I think we've all we all recognize, things that need to be discussed in our program. And a lot of things that need to be discussed should at a certain point pass through this board. And we have we have a very diverse board. We have a lot of support and we all come from different areas. We have people in industry, we have patient advocates, we have police officer, we have a lot of different people that have been purposely put on this board in order to get the right discussions going so we can send stuff to the lawmakers for them to review and turn into law, and make the best program. I mean, Utah, whenever I talk to anybody outside of Utah, they all, and I'm like, hey, how are you guys handling this? What is going on? They always say, well, we're waiting to see what Utah does. Like Utah really is creating a a market that is working. I mean, even if there's deficiencies that we all can see, people are waiting to see what Utah is doing, and our product is good, and there's not a lot of diversion, and we have a lot of things that we can be proud of, but we do need to, bring our different walks of life into this board to say what do we want to discuss? What is important from the people that we represent to talk about? And I would just love it if everybody could throw out some ideas so we can kind of, get our list nice and big of things to talk about. The legislative session is coming up, and so anything that we want to happen this year, we need to talk about. So I just want to turn the time over to you guys and say, what are some things that you guys would like to see discussed, the people that you represent would like to see discussed moving forward. And yeah, the time is yours.
Well, I'll start. I didn't have this topic until 3 p.m.
Love it.
So Cody will be excited. So I received an email, and this actually affects everyone, that the state is no longer allowing any products that are below the 0.3% threshold of THC to be sold in the state of Utah.
Whoa.
So that means any product that if it's most edibles are about 4 grams by weight.
Inside the pharmacy.
Inside the pharmacy.
Okay, and they
Oh, I
can't.
can't sell outside.
Yeah, they can't sell outside either.
Some of them
Yeah.
are greater than the 5 or the hemp program.
Right.
So this does affect, I just looked up one pharmacy. It affects about 24 of their items across the board right now. Riverside Farm is affected by this. We are one of the only producers that sell a CBD only product because we wanted state tested products out there for patients. So I don't know if it did really say this. All it says is that one of the sentences, based on law and any product currently in the medical cannabis program that has been created and tested under 0.3 is not allowed and cannot be sold. Thanks. Have a nice day.
Who sent you that? That sounds like something Cody would do.
No, it was not Cody, because Cody was sitting over there not writing an email. So.
But I can't read the rest of what should have been.
Okay, well, it does state the law and the statute, so it is in statute. So no, I haven't gotten there yet.
This didn't sound like you.
Well, I just started. So I think obviously if they're gonna enforce the statute on there, I'll probably be writing a memo with the proposal.
Yeah, well, and we have already been, I mean, we're getting attacked from the top side too, like we have
Too potent. Now it's not potent enough.
Yeah, now it's not potent enough, like.
So, I don't know what that is,
You-
what that means for patients effective as of right now. But obviously based off that email, and could you validate, does that mean? So Cody, so everything as of right now, if they receive that email, says it's all on hold?
Yeah.
Okay.
And I think back again.
As of
to,
3 p.m.
Statute of, under 26B4-201,
Yeah.
the definition of a cannabis product.
So, so Val, you can put that as an agenda.
I think
I think
that
that is an agenda item.
warrants a statement from our board.
So does that email act as a hold order on all of those products?
My email didn't say destroy. Hopefully you didn't get a separate. Well, that seems a little aggressive there, Cody.
Cody.
I want another crack at some of them to not follow.
No, I get that. I'm just saying to destroy it.
I can't,
What are you gonna do with them? Is it cannabis or is it?
It does depend where it's processed, because Utah,
It depends
a
on-
medical
depends on-
cannabis cultivator cannot legally grow hemp.
Right, that's what I'm
Right.
saying.
So what is that defined as?
Why can't?
Well, it all depends on where it starts.
Yeah.
So if it was grown as medical cannabis, it should be medical cannabis if you follow the statutory guideline. It talks about everything's supposed to go from a cultivator processor to that, and then you go and take into account 201. Or 26B-4-201 that says you're not supposed to have anything under 0.3% there. But if you're saying then, well, it was hemp anyway. Then you open up another can of worms too.
I don't think anyone said-
Not buying hemp products.
Yeah.
But it's a bigger situation. I don't have, personally, I don't think even the department has any issues changing that on.
It just requires a change,
Change.
which unless it's in interim, which it will be. That means I'm just saying those products will be on hold until May.
Don't
destroy 'em. July.
That's from Des, tell him I said don't.
It's already been sent.
Um,
They have,
done.
pharmacies have to follow the regulators, so.
Yeah, we'll put that on the agenda item. As much as I would love to continue talking about this, because that makes my blood a little angry, but we will, is there any other topics that you guys want to discuss, need to discuss for, for the people that you represent? I did reach out to our lawmakers and got a couple good ideas. Nothing I think that's not on our item tracker anyway. I do think that we need to prioritize just the funny enough, the cap on how high it can go. Maybe we could do it the same day. We'll do it all next time, talk about how high and how low we can go with cannabis medication. But because that is something that they are being asked to vote on this year, and so we should maybe talk about not necessarily raising the cap like we just talked, but like what it looks like if they add a cap. Maybe looking at it from the perspective that they're supposed to be looking at it from. And then there was another one, but I don't see it on my phone, so I'll make sure that I get that to Trevor and we can talk about that. But anything else that you guys have, throw it out here.
Yeah, I think we should address every single thing that was in that letter from Drug Safe Utah, quite frankly, because it sounds like lawmakers are going to consider those things.
Yeah.
Without, regardless of whether we have input or not, so we as a board certainly should have input, because I think there was a pretty strong response.
Yep.
To what was in that letter, one way or or another. So I think every single
Okay.
thing that was in that letter, every bullet point that he put in there and every recommendation he put in that letter should be addressed by this board.
I agree with that. If with your permission, I'll go through that, and then when we meet in a couple days, I'll stick those on the tracker.
Yep.
Sounds good. I would like to see transfer of product between patients decriminalized. Right now, if you're a medical patient and you have product that is unusable, you cannot give it to somebody without it being considered criminal.
Yeah.
Even another patient,
So even technically in your own family, like
me,
yeah, you couldn't be like, oh, this didn't work for them.
use it for myself, vice
Yeah.
versa.
And I think that one's like, maybe not good. I mean, that one's probably never gonna get prosecuted, but. Anyway, we do have patients bring that up where it's like, well, so it didn't, didn't work. Can I give it to my sister? Can I give it to my friend? And maybe let's discuss, because if they just spent $50 on it, let's discuss what that looks like. Let's discuss if there's a possibility we could make the state comfortable with some type of tracking ability. I agree that that does come up. So if you guys are interested in that discussion. Turn that on.
Yeah.
Oh, I need something from Jimmy. That makes us look.
He's not even here.
Oh, yeah, he's gone. I'll call him. Anything else? Okay, well then I think we'll move, I mean, the next item is basically, the same, we're gonna talk about the next meeting's agenda, so we will, it looks like we're gonna have JD's topic back on, maybe he'll bring a motion, and then we will talk about this below
0.3%.
below 0.3%, and maybe we'll talk about the highs and the lows, but we'll talk about that in 3 days with Trevor. And with that, we're done an hour early. Wait.
Yes.
Well, why not? Let's open it up for public comment then. Yes, come on up. Yeah.
Okay, let's go. So I'm Mindy, I'm a pharmacist, I work inside pharmacy, VI pharmacy. And I had a whole thing written up about some topics that I wanted you guys to look at. I want to skip that and go to this email that I read. It is a huge patient, but I cannot stress to you the concern I have.
I think that's it. If you wanna change the law, change it. I was just like, the funny thing is, and I don't mean to interrupt you, that.
Can you change what you
Yeah, that is just, I mean, we're just doing our job, and it's interesting that we're getting. Specifically told, with like, it's almost okay to ignore certain laws, but not other laws. One of the reasons that this actually came up was because of playing from a processor about a pharmacy putting wrong information on and send us some information to show they're making under 0.3%. But the department, they didn't know, so definitely, so, and it's been in there since the beginning, I think, right, it should, so it is statute, so. I mean, yeah, if you guys want to talk about changing that, I think the department's all on board, we would love to have, well, THC, CBD, try to everything that.
Okay, the gravity of the situation is you sent something telling every pharmacy to pull those products, and so all of a sudden these patients are in the line on low potency products. Like my number one recommended product is actually a Hugo gummy from that. It's 5 milligrams of THC, 27 I'm not like so up in there. So there's some 10 milligram gummies that are going to be below 23%. So you're forcing patients to repair those products. I know it's a lot, but I just need you guys to listen up another email. Because if you remove all those products from the system, you're putting a lot. So, yeah.
This actually would probably fall into this emergency.
I see.
We have 4 gram gummies.
I
So do you.
mean, if emergency is not something you throw out there lightly, but this is something that really could impact a lot of patients immediately.
Only medication. Oh, yeah, right, it should have never been happening.
That's why you.
So how did it, how long has it, I mean, it's been going on for?
Well, I don't wonder, if it went through the medical program and did all the testing, why can't it be in our system?
Yeah.
They said no to a CBD products, and they weren't going through all the batch testing. These are all going through batch testing. You need to let people have those products. It's insanity to force them to use the product. We're using Hazel's tincture, which I use in kids all the time, and then all this, the CBD products, like, I mean, I hate to be, look, I'm really concerned. You know.
Mindy, you and I can work on something.
Again, Chase Angelo Giles again. What I wanted to mention is something that should be on all our radar is intention in the law. Because there isn't just recreational medical cannabis, there's spiritual cannabis. There's a lot of different intentions that someone can have going in. And a big part of the discussion earlier was, you know, how do we associate what people are doing with illicit cannabis? Well, what was their intention with that cannabis? Was it medical, or was it recreational, or was it spiritual? Because that really matters, and our laws should reflect the intentions that we have for, you know, for this, but also acknowledge the reality. You know, cannabis and hemp are, but medical cannabis and hemp are both cannabis sativa L. And I do think at some point we should have some kind of hemp integration in our pharmacies, because the reality is they're all the same cannabinoids, terpenes, just in different ratios, and that's really all the law comes down to. Okay, thanks.
Thank you. Anybody online? Sweet. Okay, well, with that, there's no more discussion.
Make a motion, we adjourn.
I'll second that motion. Let's go.
Thank you.
Thank you all.